Boa tarde a todos. First, I'm going to speak in Portuguese, okay, Oscar?
Yes, please. Thank you.
Thank you. Nós damos continuidade ao curso de atualização em cirurgia cardiovascular no módulo transplante cardíaco, em associação com o Miami Transplant Institute, University of Miami. Now I'm going to transition to English. It's my great pleasure to introduce Dr. Oscar Aljure from the Miami Transplant Institute. Professor Oscar, he is an associate professor of anesthesiology and also the program director of Cardiac Anesthesia Fellowship. Professor Oscar, it is with great pleasure that I welcome you here. And Professor Oscar is going to lecture us about preoperative considerations and also anesthetic considerations in LVAD and heart transplant. Please, Professor Oscar.
Well, good afternoon, everyone. It's a great pleasure to join you guys in this great, collaboration between our institutions. It's got an invitation from a close friend, Dr. Joao Breda. We've worked together. We've shared a lot of good, bad, and not too good moments together. So it is a great pleasure for me when I received this invitation. And I'm going to use this next few minutes to talk to you guys about what do we do as an anesthesiologist when we're thinking about the perioperative management of a heart transplant. So we're going to go through a few things that I would like to share with you this afternoon. So I have nothing to disclose, but I actually have to disclose that I wrote a paper with the group of the Miami Transplant Institute that was published this year about how do we treat our own heart transplantation. Pretty much everything that we're going to talk about is what we wrote in our paper, plus other things I'm gonna show you this afternoon. So I'm disclosing this to you guys. This paper you can find for free in the Journal of Cardiovascular and Cardiothoracic and Vascular Anesthesia. So what we're going to talk about today, and then we're going to spend some time, is I'm going to start the presentation with an index case, a case that actually happened in our institution at the Miami Transplant Institute. We're going to do a quick review of the clinical context, talk a few words on epidemiology and pathophysiology, a brief overview of the current therapies for heart transplant that are relevant for the anesthesiologist. We're going to talk about the preoperative evaluation, intraoperative management, and the postoperative management. In the intro, we're going to stop a little bit on what do we do pre-bypass and post-bypass. So before I get started, I always, every time we're talking about the management of patients from the anesthesia stand of view or point of view, as much as we can, we try to do everything we do it evidence-based. We try to base our decisions on what the data says, but there's some other decisions and some other things that we do in the operating room that maybe are not backed up by data and are backed up by experience. So that's what I'm trying to bring to you guys today. What is our experience at the Miami Transplant Institute with the Jackson Memorial Hospital and the University of Miami? What has been our experience? And I tell you that when I was writing this paper about anesthesia and heart transplant, and when I was trying to look at the data to back up, what decisions we make, well, I was happy to see that, most of the decisions that we make are, evidence-based. But as I'm going to show you, there is a lot of experience, and there's a lot of this human factor and human connection that we have to have as a team to make these cases be successful. So it's a combination of evidence-based, of experience, and in my opinion, a lot of it is communication in this case, between the anesthesia team and the rest of the perioperative team, not only the surgical team, but the nursing team and everyone else that is involved in such a big operation like a heart transplant. So this is a little bit of a busy slide, but I'll start reading it for you guys. This is an index case or an example that we're and then we're going to take this as throughout the presentation to talk about this patient, and I'll tell you how this patient did at the end of the presentation. So we have a 51-year-old patient that had a complex medical history, including ventricular tachycardia, hypertension, hyperlipidemia, coronary artery disease, heart failure, and dilated cardiomyopathy. Was diagnosed with a mixed ischemic and non-ischemic dilated cardiomyopathy with severely reduced ejection fraction of 5% and biventricular failure. His treatment was started on guideline-directed medical therapy, or what we call GMT, including beta blockers, angiotensin receptor blockers, neprilysin inhibitors, and a mineralocorticoid receptor antagonist. However, the patient had to pause and discontinue his medication because of persistent hypotension. The patient was admitted with progressive shortness of breath, diagnosed with cardiogenic shock, with hemodynamic parameters showing low cardiac output, elevated pulmonary pressures, and increased pulmonary capillary wedge pressure. The intervention initially done was placement of an intra-aortic balloon pump on admission, and the patient was listed for heart transplantation. We have a donor that is a 35-year-old male patient with a history of intravenous drug use, hepatitis C, and cardiac arrest that was resuscitated successfully, and subsequent evaluation showed a normal cardiac function and coronary circulation, making him a suitable donor for our patient. So quickly, heart failure affects 6.2 million adults in the United States and can cause significant morbidity and mortality. And these numbers we take from the UNOS, but as I'm going to show you, these numbers have been changing in the past few years. And heart transplantation is considered the preferred solution for managing heart failure. It offers, multi-organ failure and better options as compared to other alternatives that I'm going to go through very, very quickly. I'm going to touch on during my presentation. This is particularly very important because as much as we wish all of our patients that come for heart transplantation, they just not come only with a balloon pump. Sometimes they have to go through several stages of their treatment, including mechanical support, and that can affect how us as anesthesiologists approach patients and how do we plan our anesthetic and how do we treat our patient before, during, and after the procedures. The cardiac anesthesiologists play a vital role in the perioperative management of these patients because we must have a full understanding of the patient's baseline disease, the pathophysiology, and we have to take care of the whole perioperative care for these patients to have successful outcomes. I am lucky to be able to do critical care as well as cardiac anesthesia, so it's for me very rewarding and fulfilling to be able to take care of some of these patients in the operating room and also take care of those patients in the ICU as well. So it's like I mentioned, and I want to keep mentioning throughout my presentation. This is a group effort and a tasking effort from the whole system, from the whole interaction between all the teams, and I cannot make enough emphasis on how important it is for this or for all these groups of physicians, nurses to continue to work as a team to have a successful outcome. So this is two graphs showing the amount of heart transplants in the United States per year. You see in the left-hand side, the graph shows a significant increase in the past few decades from the 90s all the way to the 2020s. We're almost doubling the amount of heart transplant per year. And same thing with age. If the patients that we are transplanting, we're starting to transplant older and older patients. If you see in the second and third curve here, we have patients that are now in the 50 and 60th decade of life, and patients on after the 65 or the 60th decade of their life have also becoming heart transplant recipients. So this has so many impacts and things to consider as an anesthesiologist when taking care of this patient, because like I'm going to show you, unfortunately these patients don't give us time to do an appropriate preoperative evaluation. These patients come in on an urgent basis where we have to quickly assess them and quickly assess also the other comorbidities and plan our anesthetic accordingly for a case that's going to be happening normally within the next 12 to 8 hours, which is the window that we normally get when we know a patient is going to undergo a heart transplant. Or reviewing quickly current therapies that are relevant for an anesthesiologist. So always to keep in mind that what pharmaceutical agents are normally these patients using for what we call the guideline medical therapy. Those medications include angiotensin converting enzyme inhibitors, angiotensin receptor blockers, mineralocorticoid receptor antagonists, beta adrenergic blockers, angiotensin receptor blocker, neprilysin inhibitors, like our patient had at our index case, and sodium glucose cotransporter 2. or SGLT2s. This group of medications, more than the group, the whole, the taking or using these medications with guidelines, or what we call guideline medical directed therapy, they improve morbidity, mortality, and they reduce cardiac remodeling by reducing cell death, hypertrophy, and fibrosis. I'm going to show you a few graphs on that in just a second. So guideline-directed medical therapy can really reverse left ventricular remodeling and increase left ventricular ejection fraction in idiopathic dilated cardiomyopathy. So these medications have been well studied, well published, and well researched. So it's almost a guarantee that patients that are coming to the operating room are going to be in one, two, or maybe all of these medications. And it's important for the anesthesiologist to know all the indications, side effects, and uses of these medications when the patients are coming to our operating room. There's a group of these medications called the SGLT2s. They're primarily used for diabetes. They have a special place in my heart because we have had in our operating room at least 2 patients develop euglycemic diabetic ketoacidosis. So I encourage all the anesthesiologists in the audience to always keep an eye on patients that come in with these medications, because they can get very acidotic and you just cannot find out what's going on with these patients. It's very important to remember that not a common but an unfortunate side effect of SGLT2 inhibitors is euglycemic ketoacidosis. So unexplained acidosis with a high anion gap after a heart transplant and a patient that has been receiving these medications is always a possibility. So always keep that in mind. So, and the last thing I want to say is that these medications are so effective that now we're using targeted gene therapy based on the biochemical pathways of this medication to actually direct in a better way the therapies. So it's impressive to see the tissue remodeling, like I show you guys here. When you in this publication they compared several patients, but they compared before and after treatment with goal-directed medical therapy. You see how the improvement not only in the left ventricular ejection fraction, but on the indexed mass of the actual tissue, and how much these tissues or organs are capturing blood, and what is the extent of the extracellular volume and the extracellular damage that they have, how improved it is. So it is really a well-proven therapy, and that is absolutely common in this particular group of patients that are going to be coming to the operating room to undergo a heart transplant. So us as anesthesiologists is really important, really relevant for us to understand how these medications work and what are the potential side effects in the operating room. So this is like another little skit on how these medications work. They improve function and morphology of the chamber itself. They improve or decrease myocardial tissue fibrosis, and they have improved index matrix and cell volume. All of this is well documented and studied again, and is relevant for us to know and to understand these therapies. Other therapies that are very relevant for us, that are commonly used in these patients, and that we're very frequently going to see in our operating rooms, are device therapies. Devices such as automatic implantable cardiac defibrillators, or commonly known as AICDs. Patients with biventricular pacing that are undergoing resynchronization therapy are extremely common, and it's extremely important for an anesthesiologist to know how to handle the maneuver a patient that comes with this particular device. Not only, of course, we understand that all of these, leads are going to be taken out once the recipient donor or recipient organ is going to be taken out. But as I'm going to show you in a little bit, there are some patients that have had prior operations that are going to have a very long dissection, a very long period of time before the new organ is used or is placed. So it's particularly important for the anesthesiologist to understand all of these devices, because we need to maintain hemodynamics, and we need to maintain the patient well-being while where the heart is being harvesting, waiting for the transplanted heart to be placed. Mechanical circulatory support, of course. Patients that are unresponsive to medical therapy undergo left ventricular assist devices and total artificial hearts. In our practice, we have a few total artificial hearts, but most of them come with LVAD. So patients coming with LVADs, I'm going to touch on that in just a little bit, have particular anesthesia implications, starting from the preoperative evaluation and what monitors we're going to use, how we treat them in the operating room until the new organ is in place. So they have their own set of challenges for the anesthesiologist that we're going to touch in a second. Special ward, of xenotransplantation, meaning using organs from a different species to as a source of donors. This is a trend that talks about this is the future of heart transplant. There's the first one was done in January 2022 at the University of Maryland. But we need to understand there are significant issues that we still need to deal with, not only ethical but also physiological and pharmaceutical. So I wanted to show you guys quickly. This is from the publication and the New England Journal of Medicine last year, where we see the X-ray on the top. This is a before X-ray and an X-ray on the bottom after the pig heart was implanted on this patient. And on the right hand side, you see the echocardiogram of before and after the pig transplantation. And I brought you, since I am a cardiac anesthesiologist, my favorite thing to do is to do echocardiography. So I found very, very interesting that they were able to get a TEE on a patient with a pig heart implanted. So I found that really great. And this is something that we're gonna keep seeing in the future, since we're running short on donors. Okay. So speaking on the evaluation for heart transplant, so the first thing that we always see every time there is a heart transplant alert is what we call the UNOS classification. So the UNOS is the adult, brings us the adult heart allocation criteria for medical urgency. So we go from a very, very urgent organ, which is UNOS classification 1, to an inactive patient that is UNOS classification 7. So UNOS classification 1 is the patients that are on VA ECMO, that are non-dischargeable with a surgical implanted BiVAD or an LVAD with life-threatening arrhythmias. UNOS 2 are non-dischargeable patients that have a BiVAD or an LVAD with mechanical failure, a total artificial heart, or they have been admitted to a hospital with percutaneous endovascular pump, like an Impella. UNOS classification 3 is LVAD discharge with discretionary 30 days. Meaning that they are discharged, but they have complications that including device infection, hemolysis, pump thrombosis, right heart failure, among others. UNOS classification 4 are patients that are discharged with discretionary criteria of 30 days, but with without the complication mentioned in classification 3. Patients with congenital heart disease, refractory angina, or retransplantation are considered classification 4. Patients classification 5 are patients listed for heart transplant and one other organ, which is something that we have been doing more often in the past few months and years. Our institutions, patients not only getting a heart transplant, but also getting a heart and a liver, a heart and a kidney, a heart and a lung, or maybe all three: heart, lung, and liver. So we are getting more of these patients, and these patients set their own set of challenges, because now you're not only facing the hemodynamic changes and the nuances of the heart transplant, but also after they have a heart transplant, they go for a liver transplant, which has its own set of hemodynamic goals and set of things that we need to plan out as an anesthesiologist. So it's important to remember this is our a national way of classifying the urgency for the transplant, and then this is the first thing us as anesthesiologists should look at. So the higher the number, the less urgent, or the smaller the number, the more urgent or the sicker these patients are going to be. Always, we like to keep in mind the absolute contraindications for heart transplantation, including irreversible liver disease, meaning if they have this, they will also have to undergo a new liver transplantation. Irreversible pulmonary parenchymal disease, irreversible pulmonary artery hypertension. I always like to stop that, and every time I'm teaching my fellows and my residents about which is the most important thing to look into a patient that is undergoing a heart transplantation from an anesthesia point of view, is if the patient has a history of pulmonary arterial hypertension. As I'm going to mention in a little bit, is one of the most important or one of the most common sources of complications of difficulties, not only in the operating room, but in the ICU. Right heart failure related to pulmonary hypertension. It's very important to know it, to make sure it's diagnosed, and make sure that these patients are treated when they're only undergoing heart transplantation. So it's really important um, to put as much attention as possible when there is presence of pulmonary hypertension. Other contraindications include a history of solid organ or hematologic malignancy and severe irreversible multisystemic disease. So when we do the preoperative assessment of the patients, we do what we normally do for any other patient, but there is some changes or some things that, or some challenges that we face when we're talking about heart transplant candidates. First one, we got to remember this is a multidisciplinary approach. Even though this is an urgent surgery, for the most part, we are getting better at knowing which patients are potential candidates, and we have been able to have these patients interact and be exposed to different teams in our hospital. So some patients, like I'm going to show you, have very difficult access, so we can difficult vascular access. So sometimes we have these patients go with the Department of Interventional Radiology to try to help us get access before the transplant. Or if they had any kind of hematologic issue, they get to see the hematologist before. But unfortunately, at times, that is not possible. So that's why it's so important to maintain communication with the surgical team from our side, from the anesthesia side, on how these patients, especially the higher the wounds, the more complicated they can get, and how we need to handle these issues in an urgent fashion. So it's not ideal, but is the way the system works and the way the donor comes up. So at times it can be a challenge, but it doesn't mean that that we cannot, as a team, take on the challenge and have a successful organ transplantation. COVID-19 posed a very important hurdle during the transplantation, because we actually didn't know what to do if somebody had COVID-19. We didn't even know if a patient could get COVID-19 from a organ transplant. So the good thing is that we progressed very, very quickly, looking at those patients and looking at the data. So nowadays we are not waiting to not waiting to transplant the patient that had prior COVID-19 unless they had severe disease. Our policy right now is to, if possible, wait at least 15 days since the last, positive COVID-19. And we all only look at the patients that had several or significant complications from the COVID-19. So we had loosened up our policy before. We were not transplanting any patient that had an active COVID-19 infection. Now, at this time of the year, we are not, holding a transplant because of a recent infection in COVID-19. What other factors that, what other, things in the preoperative evaluation, me as an anesthesiologist have to keep in mind when evaluating these patients? Well, of course, all the other comorbidities. Sometimes we forget that these patients are not only sick from their hearts, but they also have pulmonary disease, like I mentioned before, pulmonary hypertension, kidney disease, liver disease. So it's important to take this into consideration when planning the anesthetic. A consideration that is very important for us is arrhythmias, and it comes in hand with implantable devices. When we are planning our anesthetic, planning if we're going to interrogate the device, if we're going to turn off the device, knowing what to do with devices and how they are going to respond to arrhythmias is part of the preoperative evaluation. And very, very importantly, medications that the patient are using. Like I mentioned before, any goal medical directed therapy or guideline medical directed therapy will change the anesthetic. Antihypertensives or medications for heart failure will make the patients prone to have hypotension during induction of anesthesia or during the entire case. Patients that are anticoagulated can make vascular access challenging and at times dangerous. So it's very important to keep looking and ask the patients and look very thoroughly in the preoperative evaluation to make sure that we are aware of all the issues that the patients might present. these three things that I always highlight, like I mentioned, I always teach my residents and my fellows to always keep in mind. Number one, contraindications for TE. We got to make sure that the patient hasn't had any prior esophageal surgery or esophageal resection, making sure that the patient doesn't have any esophageal diverticulums or anything on the esophagus or the stomach that could prevent a normal evaluation with transesophageal echocardiogram. Second, very important item in the preoperative assessment is difficult intravenous access. Sometimes these patients have history of multiple venous accesses. Sometimes they have had dialysis before, multiple dialysis catheter. Sometimes they have even come to us with completely occluded vessels on the upper body, meaning IJs and subclavians thrombosed. So this is something that we need to be alert of, and we need to alert the surgical team ahead of time. So a plan can come into place on what is going to be the intravenous access for these patients, and not only intravenous access, but also intravenous or intravascular monitoring. And another thing that sometimes we forget is that at times cardiac anesthesiologists are called to manage donors. So we need to understand not only the pathophysiology and the physiology of the recipient, but also of the donor. So never forget that us as anesthesiologists can get involved in that. Speaking directly on the intraoperative management, so is paramount, or we cannot stress this enough on how important it is to have preparation. Preparation for a successful heart transplant is mandatory in every successful case. Where does the preparation start? Well, planning in how do we transfer our patients from the ICU or from the floor, from the ward, to a fully prepared operating room. So a lot of work has been done, a lot of data has been published into this. So in our institution, we have created a protocol of transferring patients from the ICU to the operating room, and from the operating room to the ICU. We have created a written format that needs to be filled out with with all the patient information, hemodynamics, history, and events, not only in the ICU but also in the operating room. And we do same level of care sign out, meaning the nurses sign out to the nurses, the mid-level providers sign out to the mid-level providers, and the attending physicians sign out to the attending physicians, both from the ICU to the operating room and from the operating room to the ICU. So with this, we ensure that we are not missing any important issue or any data that can be relevant for the management of the patient in the operating room, and then we prevent missed calls and missed things in the treatment of the patient. So that is absolutely paramount and relevant. Just from when you start in the case, make sure that you get if the patient is coming from the ICU, making sure that we get a proper sign out. This is something we've been working with a lot, which is coordination with the procuring team to prevent delays and minimize organ ischemia. So as simple or as easy as it can sound, talking and planning on the timings of both the recipient and the donor in the OR, taking into consideration the distances that the organs travel, can affect how we take care of these patients. It's not the same thing to bring a patient that is on a balloon pump, like our patient that we're describing in this presentation, that can easily stay in the operating room, is easily transferred from the ICU, can wait for an hour or two for the organ to come, as compared to a patient that maybe is on VA ECMO and that has dialysis, or that has other mechanical support in place that can make the transport and the care of that patient very challenging in the operating room. So we can avoid unnecessary waits in the operating room. So again, communication between the anesthesia team, which I speak for, or two, and the surgical team is paramount for this particular goal. What things can delay the recipient preparation? Well, like I mentioned, travel time, preoperative interrogation of implantable devices. As much as we would love to, sometimes we don't have enough time to interrogate the devices. So we like to use for implanted devices in the operating room, magnets. For us anesthesiologists, challenging airway or difficult vascular access, that's something that we cannot plan for unless we have seen the patient in the clinic before. But seeing or having a patient with a challenging airway can, make us use more time than normal in the operating room. So we always should make time for this or be prepared for this. And of course, surgical considerations that can delay the preparation for the recipient. Of course, like I mentioned before, presence of mechanical support, needing the reverse anticoagulation of patients that have had prior sternotomy or prior thoracic surgery can make dissection and harvesting of the organ from the recipient very challenging and difficult. What patients are at increased risk for complications on this particular portion of the surgery? Well, patients with prior cardiac or thoracic procedures. Why? Because there's a high risk of right ventricular or major vascular injury, and presence of adhesions as scarring tissue can increase dissection time and bleeding. So for us, knowing that or keeping that into account as anesthesiologists, we can be more ready to take care of these patients. We can have more blood products available in the operating room. Maybe we can use lung isolation techniques that can make dissection easier for the surgeon in case of a lateral approach for the surgery. This can be very relevant and can affect and alter the anesthetic or the management for the patient from the anesthesia side. We have patients in our institution that have undergone prior LVAD placement, what we call minimal invasive, or using instead of a sternotomy, using a lateral thoracotomy. So knowing all of these things can, for the anesthesiologist to be aware, to have to know about all of these characteristics of the patient can really make an impact on the patient, make an impact on how much bleeding, how much products are going to be used, and how we plan the rest of the surgery. So it's absolutely relevant for us to keep that, those considerations at all times. So, like I mentioned before, as much as I wanted to use data or to look at articles on how to, back up our decision making in the operating room, some of the decisions that we make are based on experience, and then experiences have been published, and that's what a lot of institutions use, here in the United States. Speaking about anesthesia monitors, we in our institution we do standard monitors, of course, EKG, pulse oximetry, blood pressure. Arterial line, we like to place an arterial line pre-induction of anesthesia on every patient. We do bispectral index, and also we use cerebral oximetry. Cerebral oximetry is very controversial about the use, not only in heart transplantation, but in cardiac surgery in general. There is insufficient evidence to recommend its use to reduce mortality or organ-specific morbidity after cardiac surgery, but we continue to use it. Actually, was fortunate to participate on a review that is published in the same Journal of Cardiovascular and Thoracic Anesthesia about the uses of cerebral oximetry in cardiac surgery. And our conclusion, like I mentioned, is not there is not enough evidence to recommend its use, but there is good data showing that the trend, or using a baseline number for cerebral oximetry, the device I'm showing you here on the right hand side, with and here on the right up as well, that following the trend and following knowing what the baseline numbers for the patients can have some use, and it can have impact not only in the ICU, but at a later date, since there had been a good correlation between lower cerebral oximetry values and cognitive decline 2 years later in patients undergoing cardiac surgery. So even though there is not enough evidence, we in our practice, we in every heart transplant, we use a BIS monitor and a cerebral oximetry. Like I mentioned, we do pre-induction arterial line, but we not always do pre-induction central line. We do a pre-induction central line in patients that have a prior sternotomy, what we call a reduced sternotomy, in patients that we foresee that are going to need a vasopressor administration. We like to place a central line. We normally use a large bore central line. We either use a 9 French or a 13 French introducer, and through our 9 French, we place a Swan-Ganz or pulmonary artery catheter on every patient. We use defibrillator pads on absolutely every patient because, like I mentioned before, the high incidence of arrhythmias in these patients. And I also like to make a comment on patients with prior lines. A lot of these patients that have, PICC lines placed for therapy at home, patients that are on milrinone infusions at home, they can come with lines that are as old as a year. So at the MTI, we like to replace this Any line that has been in the side of the patient for more than 10 days, by our protocol, by our policy, is taken out to prevent any incidence of infection. And this is after discussion with the infectious disease department in our hospital. So on the pre-bypass period, a quick word on patients that have mechanical support. So it's been said that about 43% of patients undergoing heart transplant have some kind of mechanical support, from all the way from an intra-aortic balloon pump, an Impella, all the way to an ECMO. They have it. So we have to be, as anesthesiologists, prepared for this. We also have patients that have LVADs, HeartMate 3s, HeartMate 2, and HVADs. Even though they have been discontinued, we continue to see patients that are organ recipients that have this therapy. So we got to remember that these are non-pulsatile, devices that make pulse oximetry and non-invasive blood pressure monitoring unreliable. So we are aggressive, and we like to place an arterial line on every patient, before induction of anesthesia. These particular patients that have mechanical support coming into the OR are at high risk of vasoplegia and bleeding. This is secondary to vascular remodeling, acquired von Willebrand disease, acquired factor 13 disease, and history of oral anticoagulation. So this is just to say that these patients can get very hypotensive after induction of anesthesia, and definitely can bleed a lot with intubation, with line placement. So it's very important to have an experienced, person do these procedures. In our institution, these are fellow level cases. So we normally don't have residents. Rarely we have senior residents do these cases, but for the most part, we have fellow cardiac anesthesia fellows intubate and put lines on these patients, or of course the attending. Key to maintain hemodynamics and organ perfusion while the dissection is happening. So that's all we need to do. That's our focus during the pre-bypass period. Something that is relevant and that people tend to forget is that there's always a delay response to medications. So these patients have low ejection fraction, low cardiac output. So these patients take a while to respond to medications, including to hemodynamic support. If you bolus them vasopressors, norepinephrine, epinephrine, is going to take a while for those patients to respond or to have a response to that medication. So you got to plan for that. If you wait too long, or if you don't plan that out, you can end up with in a bad hemodynamic situation. So it's important to make sure that the entire team understands that there's always a delay response for these medications. One of my favorite things to say in the operating room for my trainees is that these patients need to have right ventricular preserving anesthetic goals. So anything that we can do, or everything that we can do for this patient, has to be focused in trying to preserve the RV function. So what are the anesthetic goals? Well, making sure that the patient never gets hypoxic, hypercapnic, hypothermic, or has increased pain. Of course, keep in mind also acid-base status, making sure that they're not acidotic. So anything that can increase the afterload to the RV, we need to do, because these patients can become very unstable for while the dissection is happening. So we want to maintain their hemodynamics as best as we can, and the best way is to think about what can I do to preserve this patient's RV function. In our institution, we do routine TE for everyone, and like I mentioned before, central line and pulmonary artery catheter for everyone. We like to do a pre-bypass TE. Some people don't do it. We like to have a baseline to know what was the patient's function before. We like to, confirm the diagnosis of heart failure, and also look for thrombus on the recipient heart, presence of effusions, either pleural or pericardial, that can be addressed by the surgical team. And we like to use it for hemodynamic monitoring as well. These patients can get very sick and very unstable while they're getting dissected. So it's very important we use a lot the TE to help us, on the management pre-bypass. This is an example of another TE, for example, showing this is a transgastric right ventricular view on a patient, on a recipient that had a thrombus from an AICD lead. So these things this thrombus can end up in systemic, and we really want to make sure that the surgeons know that this is the case. So we look for this things when taking care of these patients, so we don't have so we can have a successful outcome for our patient. So this is a summary of transesophageal echocardiography findings and views in the setting of heart lung transplantation. So this is a lot of letters here that maybe my colleagues, my colleague anesthesiologists or cardiac anesthesiologists in the audience probably understand. But just to show you how important and how relevant is for us the transesophageal echocardiogram. That's why we want to make sure that this we address, or that we know the patient has any contraindication for TE before the heart transplant. So things that we look for, of course, systolic and diastolic dysfunction. If we want to see if there's pressure overload, volume overload, valvulopathies, shunts, masses, thrombus, intimal flaps. This is before and also after we, like I'm going to show you in a moment, we can look for primary graft dysfunction, hyperacute rejection, air in the coronaries, air in the endocardium, severe pulmonary hypertension, if there was poor myocardial protection, valvulopathies, shunts, thrombus, dissections afterwards. So it's an invaluable tool for us as anesthesiologists. That's why we routinely use it in every single case or every single patient that is undergoing heart transplant. Things that we as anesthesiologists do during the bypass period, people think we don't do anything, but we do. We in our particular institution, we have a pulmonary artery catheter that has been passed into the pulmonary artery, or we like to withdraw it, and we like to make sure that that our at least one port or the CVV port is at the SVC, so we can measure and monitor the circulation, the upper body venous circulation, looking for SVC syndrome or an over tightened SVC cannula that can end up in cerebral edema. So we routinely, do that with our PA catheters. Our institution, when which is most, is routine the use of the PA catheter. We like to communicate with the surgeons, and our surgeons are nice enough to help us reposition these PA catheters. During the bypass period, if the patient is undergoing a bicable approach, there's less incidence of conduction abnormalities. We like to prepare for any type of arrhythmia or any type of chronotropic support, knowing which approach has the surgeon used for the heart transplant. During the bypass period, we also, at the beginning of the bypass, we always alert for cannula malpositioning, especially on patients that have reduced sternotomies. It's part of our responsibility as anesthesiologists to make sure that that these, the cannulas are working well, are in the right position, and we can also help diagnose cannula malpositioning. And also during bypass period, we like to get our medications ready, transplant immunosuppression medications that are administered normally before the cross clamp is released, including steroids and anti-rejection medications. And we prepare with intropes and chronotropes after the release of the cross clamp. So that's what we do during the bypass period. Inotropes, we use a combination of epinephrine and milrinone. That is our institution policy, or what we normally do. We sometimes use dobutamine plus or minus in combination. Several studies have been done trying to compare different types of inotropes, different combinations, and not a single combination of medications have shown a better outcome. For chronotropy, of course, the newly transplanted heart is dependent directly on the circulating catecholamines for chronotropy or pacing. So we are very big on pacing. We have 2 pacing boxes in every case when coming off pump. As as we see a significant amount of bradyarrhythmias in our patients, up to 50%. Also, during the bypass period, we'd like to get our RV offloader or RV afterload medication ready. In our institution, we're grateful to have nitric oxide. So we routinely use for every patient. So every patient undergoing a heart transplant at the Miami Transplant Institute at Jackson Memorial comes off pump on nitric oxide. When nitric oxide is not available, we use prostaglandin, inhaled prostaglandin as well. But for the most part, we have nitric oxide available. Always, we like to have a discussion on mechanical circulatory support, including ECMO for the patients. We like to plan this out with the surgeons. We like to communicate and talk before the case starts. And if there's patients that are high risk of having issues, history of significant pulmonary hypertension or any other comorbidity, we are aggressive in coming off pump on ECMO. Sometimes what we do is that we come off pump on partial ECMO or partial bypass, like I'm going to show you in a moment. But the highlight I want to do is that we communicate, we talk with our surgeons, and we plan this out. So it does not come as a surprise for anyone. One thing that we also like to do during the bypass period is we encourage our perfusionists to hemofiltrate the patients. A lot of these patients come with a high intravascular volume, fluid overloaded, so we use this bypass period to hemofiltrate these patients and to help us with their fluid overload that they're coming with. So weaning from cardiopulmonary bypass, probably the first thing that we like to do when we have our medications, when the cross clamp has been released and we're waiting after taking off the clamp, when we're waiting to come off pump, first thing that we look for is air in the coronaries, like showing in this echocardiogram, air in the tissue and the endocardium. So we are very particular and we are very patient. We like to pace and we like to give the patient time for that air to come out. And we do give a significant amount of time to this issue, because it can give us problems later when we come off pump with air on the right coronary circulation, RV failure, which is one of our most feared complications. Always keep in mind as an anesthesiologist that a graft dysfunction can start as soon as the cardiopulmonary bypass is weaned. This graft dysfunction can be classified in primary, which is a dysfunction of the organ itself, or secondary from hyperacute rejection, pulmonary hypertension, like I mentioned before, or a non-surgical complication, problems with sutures, anastomosis, and so on. We like to, in anesthesia and TE, we like to classify the primary graft dysfunction between left and right, and there are some specific findings on the echocardiogram that we should look for when a patient has each one of those. This I'm showing you this echo here, a patient with significant amount of air in the septal wall. This is from a 4-chamber view, and this is the same patient after coming off pump. Oh, this video is not working. My apologies. Oh, it is actually, and showing a significantly dilated right ventricle after coming off pump when not properly de-aired. So that's one unwanted issue, or that we don't want to have. It's just to have, for not being patient enough to have air in the coronary circulation and have someone end up on ECMO or with our right ventricular dysfunction just from air. Like I mentioned before, we do TE assessment for specific left-sided or right-sided primary graft dysfunction. For left-sided, we look for global LV hypokinesis, ejection fraction of less than 40% when quantified by 3D, which is our preference, mitral regurgitation, and RV dilatation. When we're looking at our RV dilatation secondary to the dilatation of the left ventricle, meaning when we have biventricular failure, it is classified as left-sided primary graft dysfunction. Right-sided primary graft dysfunction, we have RV dilatation. We like to use tricuspid annulus plain systolic excursion, or TAPSE, less than 12, or a fractional area change of less than 25%, tricuspid regurgitation, or an unloaded left ventricle, or a left ventricular end diastolic diameter of less than 38, or a right to left ratio of more than 0.7, using the diameters at the end of the diastole between the right and the left, meaning your right ventricle at the end of the diastole should never be 0.7, in a ratio of 0.7 higher than your left ventricle. So keeping this in mind, or looking at this these parameters can help us elucidate if the patient has biventricular or left only or right-sided only graft dysfunction. For the most part, and what I keep insisting throughout this lecture and to my trainees, is always focus in right-sided primary graft dysfunction, because it can be secondary to pulmonary hypertension and comorbidities that the patients have had in the past. When we wean from cardiopulmonary bypass, we do prolonged reperfusion, like I mentioned before, with a good amount of pharmacologic support, while do examination of the heart on full load, full bypass, partial bypass, or off bypass. We know that if there's severe primary graft dysfunction, this is associated with poor survival, and we like when we see a severe graft dysfunction, we call for VA ECMO. So some studies have shown that patients that are started on VA ECMO could do better, can have better outcomes. Mismatch for normal donor RV and increased PVR can result in delayed RV failure. So unfortunately, the RV failure can be seen later on, maybe not even in the ICU, but not in the operating room, but in the ICU. So that's why it's important to take all these, preventative measures, look at all these monitors and try to, prevent this as much as possible. We like to do an echocardiographic evaluation while coming off bypass of all the vascular anastomosis, looking for pulmonary artery stenosis, looking for turbulent flows, high Dopplers, and things like that when coming off pump. In the post-bypass period, we do close titration of vasoactive medications. We have always, like I mentioned, a preoperative consensus and open communication with the surgical team about the mechanical support. A big one, probably for us and for everyone else, is coagulopathy. In our institution, we use thromboelastography to direct or to help us titrate our coagulation therapy. In our institution, also, we have a very low threshold for the use of prothrombin complex concentrate, especially in the presence of RV failure. So we are strong believers that high volume or high amount of volume of blood products can be detrimental for the RV failure. So we are aggressive with the use of prothrombin complex concentrate for coagulation. Is low volume with high, with a very good response in coagulation. So we advocate. We advocate, but that's our practice. That's what we use. Vasoplegia. We call vasoplegia when the MAP is less than 60 with a normal cardiac output. Always beware of adrenal insufficiency. Patients that have been on steroids before, it's always important never to forget to do stress dose steroids during the operation. Other therapies that are uncommonly used for vasoplegia, such as methylene blue and hydroxycobalamin, has been used in our institution, especially methylene blue. That's why we always look in our preoperative evaluation for glucose 6-phosphate dehydrogenase deficiency, or maybe the patients are taking antidepressants, SSRIs. They can have an interaction, and the patients can end up with serotonin syndrome. Unfortunately, we have had a couple of those in our institution. But that's not the case anymore, since we are more aware and we are assessing for that in the pre-op evaluation portion. Novel agents such as angiotensin 2 agonist and vitamin C as off-label items for rescue. We're not using as much. Angiotensin 2 is coming. We use it at one of our institutions, but now it's gonna be coming hopefully soon to the Miami Transplant Institute. It's a very potent drug, but always keep in mind that a big contraindication for angiotensin 2 agonism is preventricular failure. And at the end of the post-bypass period, we'd like to use a checklist of things that we assess for, that we look for before we plan to go to the ICU. That includes a new assessment of the LV, RV valves with the echocardiogram. We look for pulmonary systemic pressures, cardiac output, acid-base state, mixed venous saturation, pharmacologic support, and coagulopathy. We put this all in a sheet, and we transfer the patients to the ICU with this sheet in our hand, assessing, or with this checklist, making sure that we're going over everything that the patient needs to go or to be into. Last but not least, not as much of my idea with this lecture, but things that we see also, that I get to see also in the ICU after a patient comes in the immediate postoperative period after a heart transplant. Of course, hemodynamic management. Some things that can work in the operating room cannot work in the ICU. So in the ICU, we're more liberal with use of other inotropes. But the thing to remember for us as anesthesiologists is, again, the hemodynamic conditions and the OR can be very different to hemodynamic conditions in the ICU. So it's important to keep this in mind when signing out and when matching these patients. Again, presence of cardiogenic shock in the ICU calls for early mechanical support. So we have a very strong ICU team that is always communicating with our cardiac surgeons, and we like to establish early mechanical support if we think the patient needs it. In our institution, we are very aggressive also with TE. If needed, we bring a TE to the ICU, and we use information from the cardiac output monitor, the PA catheter, the central line, and the TE to make decisions on early mechanical support for left-sided or right-sided failure or biventricular failure. Bleeding is the ICU, of course, in patients that have had prior thoracic operations, prior sternotomies. Bleeding can be a major game changer and the patient's outcome for the reasons I mentioned. So we also advocate early use of prothrombin concentrates in the ICU as compared to high loads of blood products. Mechanical ventilation can be another big one for us in the ICU. We have to use not only lung protection strategies, but also RV protection strategies. High intrathoracic pressure and high PEEPs can be sometimes poorly tolerated, but also hypercapnia and hypoxia can also be poorly tolerated by the RV. So it's a lot of strategies, a lot of changing things with the ventilator in the ICU to try to prevent prevent the need for mechanical support or the patient to go on RV failure. Renal failure is one that we don't like to see too much. There's good data showing that presence of renal failure on the immediate post-op period is associated with worse outcomes. So we try to maintain renal perfusion pressure as much as possible, and we are very on top with, of course, a big team, including nephrologists, in the immediate post-op period. Immunosuppression, just a word for the ICU that can have significant interactions with medications and pressors and inotropes that we use that the patients come from the operating room. There's immunosuppressants that can give the ICU team changes in the hemodynamics and the changes in the metabolism of other drugs. So it's important to always keep in mind which drugs are being used for immunosuppression and which drugs am I currently using to maintain the patient's hemodynamics. So to finish the management of our index case that we described at the beginning of the talk. So this 51-year-old on presentation was determined that he was not an optimal candidate for an LVAD due to biventricular failure. He was placed on a heart transplant list. He needed an intra-aortic balloon pump to maintain hemodynamic stability. He was taken to the OR, spent 111 minutes on bypass, and the allographic ischemic time was at 183 minutes. Post-transplantation TE, he showed a good biventricular function and no stenosis or anastomosis issues. After the heart transplant, the patient's balloon pump was removed. The next day, once the RV function was felt to be stable, the patient was placed on sildenafil after weaning inhaled nitric oxide for RV support. And postoperatively, the patient required epinephrine and vasopressin drip that were weaned off slowly with maintenance of hemodynamic stability, and the patient ended up doing well and going home. So that's what I have for my talk. Happy to entertain any questions. Thank you, everyone, for your time.
Thank you, Oscar. Thank you so much for this absolutely great presentation. And I can assure that we can say that surgeons and anesthesiologists, we are the real partners in this whole scenario. More than our relation, our partnership with the heart failure cardiology, the ICU physicians, at some point, all the decisions and the important part of surgery, these decisions are going to be made between us. So I would like to take advantage of our Brazilian audience to say thank you for you and our team of anesthesiologists. It has been a source of learning for me this whole time here in Miami. And you guys are excellent specialists, doctors, and you are doing an absolutely great job in taking care of this complex patient. As you said before, we already shared good and bad cases, and which reflects the complexity of these patients. So with your permission, Oscar, I am going to make some highlights about some comments about your presentation, but I'm going to give you a chance to train your Portuguese now, okay?
Okay, sounds good. Obrigado.
Bom, com a permissão do professor Walter e do professor Nelson, eu gostaria de destacar alguns pontos da apresentação do Oscar. E ele começou colocando um tripé extremamente importante quando a gente fala no tratamento desses pacientes tão complexos que são os portadores de insuficiência cardíaca avançada, e aqui a gente está falando especificamente do transplante cardíaco. Então, ele começou dizendo que toda a nossa prática, ela precisa ser evidence-based. Então, tudo está guiado na medicina, nas práticas baseadas nas melhores evidências. Mas quando a gente está lidando com esse grupo especial de transplantes, de pacientes que são aqueles que vão ser submetidos ao transplante, o Oscar trouxe que nós temos que levar em consideração a experiência de todo um grupo, e ele falou várias vezes durante a sua apresentação a respeito da comunicação. Isso realmente é um ponto extremamente importante, que é essa comunicação entre o time, e nesse momento fundamental, que é o momento do ato operatório. No transplante de coração, todos vocês sabem muito bem disso, a diferença que faz um caso que vai bem no centro cirúrgico com um caso que apresenta algumas intercorrências. Então, só para chamar a atenção, o time de anestesia aqui em Miami, ele é dedicado. Então, nós temos um grupo com 5, 6 anestesiologistas voltado exclusivamente para a parte cardiotorácica. E mesmo o Oscar tendo dito que muitas vezes eles vão ter 4, 8 ou eventualmente 12 horas para manejar esse paciente uma vez que o coração é aceito, eu queria ressaltar com vocês que o anestesista ele está presente desde o momento da decisão de listar esse paciente. Então, nos nossos meetings multidisciplinares, o grupo de anestesia está lá para participar desde a indicação do transplante. E lá já se tem conhecimento se esse paciente tem um LVAD, se esse paciente é um paciente de maior risco para sangramento, dificuldade de acessos e tudo isso. Então, daí a importância dessa comunicação e desse grupo multidisciplinar. E, por fim, uma coisa que eu queria comentar com toda a nossa audiência, a nossa plateia brasileira, é a importância do ecocardiograma transesofágico. Eu sei que essa é uma prática constante, regular no Brasil, mas eles são verdadeiros especialistas em ecocardiograma transesofágico. Só para dar uma ideia a vocês, quando esse paciente está lá na unidade de terapia intensiva, muitas vezes, qualquer intercorrência, nós pedimos para um deles nos acompanhar até o UTI no pós-operatório para nos ajudar no manejo através do eco transesofágico. A gente, muitas vezes, não chama o cardiologista de plantão ecocardiografista. A gente pede para o grupo de anestesia fazer, tamanha a expertise que eles têm com essa técnica. Então, eu gostaria agora de passar a palavra para o professor Walter para que ele possa conduzir a nossa discussão. Muito obrigado.
Well, I'd like to thank again to Oscar for the outstanding talk about this topic. And Oscar, we have some questions from the floor. The first one is from Mary dos Santos Silva. She's questioning if the cerebral oximetry if the cerebral oximetry monitor is done right now with the NIRS, the near infrared spectroscopy,
Yeah.
what you have to comment about, please?
Yes, absolutely. Yeah. So we do cerebral oximetry just like she says with near infrared spectroscopy. We use it routinely on every patient undergoing heart transplant. And we, like she says, we use it bilaterally. I showed a picture on my presentation. I don't know if I can share now. Let me see. So I can show her what I'm talking about. Let me go back here. This is exactly what we use. Can you guys see my presentation now again?
Yeah.
So we do use bilateral because the machine, you see this monitor on the bottom, it gives on the top, it gives us a number, left-sided and a right-sided uh, cerebral oximetry. So we use it. We don't make many decisions based upon desaturation, but we do like to see that our patients' cerebral oxygenation doesn't decrease below the baseline during the operation. To give you an example, if we see that the cerebral oximetry is going down under the baseline during the bypass portion, we like to ask, in communication with the surgeon, the perfusionist, to increase the perfusion pressure or the MAP on the pump, so, and to see if that has any kind of impact on the cerebral oximetry. We sometimes change, how much oxygenation we're using for our patients if we see decrease in oximetry. So more than the number itself, what we like to see is the trend, and we like to see like this, like in this slide here, we like to see a flat trend if possible, or maybe a trend up that is looking or moving upwards. We don't like to see a cerebral oximetry that is coming down, because that can, tell us that maybe the patient is having, cerebral desaturation. Is not, there's, like I mentioned in my talk, is not enough evidence to suggest that it may change the outcomes or the morbidity or the mortality of the patients. There's not enough data. There's some data showing, improved or better cognitive outcome when you keep those numbers higher in elderly population, but there is not enough data to say that you should mandatory use it. In our institution, we have the technology, and we'd like to take advantage of it as much as we can on every patient.
Thank you. Next question is from Carlos Carrillo. Professor Oscar, thank you very much for a brilliant presentation. My question is about the process of a DCD heart transplantation. What will be the specific procedures in the donor and the recipient?
Yeah, so for DCD, our group, we don't take part of the management of the donor itself when it comes to DCD. That is, that is taken care of, at the donor side by the group, but the groups that that go with the donor surgeon. But for the recipients of I'll tell you that the biggest thing for us is timing. Every time an organ goes to DCD, and the timing is what changes, and the preparation for the arrival of the donated heart is what we can alter what we do. But in terms of preparation into anesthetic considerations from a specific DCD donated or DCD organ, our approach is very similar to what we do to a regular any regular recipient. Yep.
Okay, thank you. The next question is from Mauricio Fortuna. With regard to the denervated transplant heart, despite the surgical techniques of implantation, which dose of inotropes must be used before the indication of mechanical support? I think he's trying to link how high has to be the inotropic dose before the indication of the mechanical support.
So yeah, so we I cannot give you a set dose of medication that we use, because this is, like Dr. Breda was mentioning, this is a very fluent decision between the surgeons and ourselves. I'll tell you, we use doses here. We use in milligrams per kilo per minute of norepinephrine and epinephrine. Norepinephrine, we try to stay away from since we want to protect the RV as much as we can. So we use vasopressin up to doses of 0.08 units per kilo per minute. And we use epinephrine as high as 10 or 12. So when we're maxed out between 12 of epinephrine, vasopressin. We also use a loading dose and doses of milrinone up to 0.5. We don't like to go any higher than 0.5 micrograms per kilo per minute because it causes vasoplegia. So when we have a mix of those three, vaso, milrinone, and epinephrine, and very high doses, meaning 0.5 of milrinone, about 12 or 14 of epi, and vasopressin 0.08, we start, and we don't see an improvement on the echocardiogram. We start seeing signs of hypoperfusion. We start seeing high lactate. We start seeing high base deficit, low urine output, low cardiac output. Despite all of this, then we consider doing ECMO. One thing that we've done is that we don't go on systemic ECMO. Sometimes we go on right-sided ECMO if the issue is just right-sided failure. So Dr. Vera can illustrate us more on that. But we know we place a cannula on the pulmonary artery and we keep the venous cannula from the bypass machine. And then we stay on right-sided ECMO for as long as we need to be to see if the medication requirement decreases. So it's not like a set dose that we say, okay, after this we go on ECMO. It's a very fluent discussion with the surgeons and to see, and there's a response on the patient, to the medications. If maybe the cause of the shock is maybe not cardiogenic, if it's just vasoplegic, when sometimes going on VA ECMO is not going to change much. So again, it's a very fluent discussion, between us and the surgeons to make those decisions.
All right, thank you. Next question is from Alvaro Perazo. It says that considering that the HVAD has been discontinued in relation to the HeartMate 3, if there's any specific procedure for the LVAD replacement surgery in your anesthesiology practice?
Yeah, absolutely. Yes. In like you say in your comment, even though it has been discontinued, we continue to see HeartMate 3s in our practice. That's what we're doing. So, but if you mean if we do any changes, in the practice if somebody has a HeartMate 3 or a hardware coming to the operating room for a heart transplant, the answer is no. If we do any changes when a patient has a hardware or a HeartMate 3, the answer is yes. In terms of monitoring, we have seen that depending on the procedures that the patient is undergoing, having a HeartMate 3 can make non-invasive monitoring easier with pulse oximetry and with non-invasive blood pressure monitoring, and as compared to a hardware. So to conclude the answer, yeah, if they're going for a heart transplant, the answer is no. The treatment is the same. If they're going for a non-cardiac surgery, the answer is yes. We treat them differently in terms of monitors. Yep.
All right. Now I have some questions by my own. Oscar, you have been telling about the vasoplegic syndrome. How high is your incidence of post-operative vasoplegic syndrome, and then does it increase your morbidity and mortality rates in the peri-operative of heart transplantation? Do you fear vasoplegic syndrome?
Yes, we unfortunately is quite high. So, and it comes in hand with how the patient comes to the OR. We see a lot of vasoplegia on patients that come with mechanical support. There is some data showing that there is a higher incidence of inflammation in these patients. So people that come with impellas or they come on VA ECMO, there's a high circulation of inflammatory cytokines that make these patients prone to have vasoplegia. And unfortunately, we see it quite often. I'll tell you, probably more than 50% of our patients that come for heart transplantation with mechanical support on board have vasoplegia, and it does affect their outcomes. Not only in the OR but in the ICU. That's why we are, we're doing actually part of studies right now of drugs to use invasoplegic shock. We're bringing to our institution right now angiotensin II agonist, which is very potent but cannot be used for IV failure. And we have been part of trials with hydroxycobalamin, with vitamin C, with IV levothyroxine, and methylene blue, or combinations of all those. We have tried everything because we do have a lot of asoplegia, unfortunately. But probably our highest incidence is with patients that come with mechanical support to the OR. Yeah.
That's the same as experience we have over here. I notice you don't have problem taking patients with taking donors with hepatitis C. And what about HIV? Do you have a restriction on patients with HIV?
Professor Breda. we do not have right now restrictions. What we do is we try to we match the recipients and the donors when they have viral transmissible diseases. We try to match them. That's what we do.
Yeah, and I don't remember any recipient that we had done recently with the HIV. Do you remember, Oscar?
Yeah, hearts. No, we more kidneys and other organs we do, but hearts not. And if something like that happens, we match both. We have to match both recipient and donor. Yeah.
Yeah, and we are, just for curiosity, we are changing our policies, and we just did a review on the HIV policy. I think it was 2 weeks ago, and it still is a matter of debate here, Walter. The things are still in process here, so I don't have a clear answer yet. We are in the middle of this policy review for possible HIV recipients now.
And the last question is from Mauricio Fortuna. Does isoproterenol still have a place in your practice?
Very little use. Yeah, we use it very little, not in the ICU. We use it not in the OR, but in the ICU when we just need pure beta 1, pure chronotropic support. For us, we see a lot of arrhythmia. It's very, very arrhythmogenic. Actually, our biggest use of isoproterenol is on the electrophysiology lab to induce arrhythmias for VT ablations. So in the ICU, we rarely use it. We have used it, but since it's so pro-arrhythmogenic, all of our patients end up with ventricular arrhythmia. So that's something we like to prevent when possible. So it does have a place, but it's not as frequently used as it was in the past. Mm-hmm.
Maybe in the Hail Mary situation, Oscar.
Correct, exactly. Yeah, very last resort when nothing works, the pacer doesn't work.
Yeah.
I'll tell you, we probably we try to place a permanent pacemaker before we use isoproterenol. Yeah.
All right. Oscar, I'd like to thank you. I'm going to finish the session, but I'd like to talk not for the excellent lecture, but for the excellent discussion as well. Thank you very much for being with us, and hope to see you next time. Thank you very much.
Thank you for having me. I appreciate it. Thank you very much.
João, quer fazer encerrar, por favor, para nossa audiência em português?
Eu agradeço mais uma vez, agradeço a todos. Tem sido um grande aprendizado cada sessão que nós estamos vivendo, uma semana. Nós temos aprendido mais do que a anterior, e eu aproveito para agradecer mais uma vez a Unifesp, ao professor Walter, ao professor Nelson, professora Solange, a todos vocês. Desejo uma boa noite a todos e à nossa audiência, e deixo as palavras finais para o professor Nelson para encerrar.
Nelson, você encerra.
Bom, não tenho muito o que complementar. Gostaria de agradecer novamente. I'm thanking you again, Professor Oscar, for the brilliant presentation. Thank you so much. And on behalf of the Cardiovascular Surgery Division at Paulista School of Medicine, we all thank you. Encerro essa atividade cumprimentando novamente essa grande iniciativa da cooperação vencedora, né, entre a Escola Paulista de Medicina e o Miami Transplant Institute. Nos veremos novamente na próxima semana. Uma boa noite a todos.
Bye. Nice to see you.
Bye. Thank you.
Thank you.